Alright, so I think we have 6 viewers. I'm not sure if this is working, so if it's not, please let me know. Hi everyone, and welcome to Implant Compare. My name is Dr. Thomas Nguyen, or you can say Nguyen or Nguyen. I'm not really sure how you should pronounce it, so if there's anyone from Vietnam watching, I'm very sorry. I'm a periodontist in Canada and currently teaching at the University of Montreal. Just need to full screen my presentation. Okay. So the topic that I'm going to talk to you today is the socket shield technique. Before we start, I just want to thank Blake and his team at Implant Compare who made this event possible today. I think it's a wonderful platform. You can watch free webinars and live surgeries. So the socket shield technique is a relatively new procedure which only recently became popular within the implant community. There are a few publications only, and there's no available standardized protocol yet. My team is currently working on researching the socket shield technique, and we're currently writing a paper to suggest a standardized protocol that can use in other research projects, so we can have more data on this wonderful technique and someday make it evidence-based and available in your clinical practices. So for those who don't know me, I'm just going to briefly introduce myself. I graduated from the University of Montreal for my dental school, and then I did a year of AEGD at the Eastman Institute for Oral Health. I've completed my master's degree at McGill University, and finally I did my periodontal residency at the University of Minnesota. Currently, I'm teaching at the University of Montreal as an assistant professor, and starting this June, I will be an instructor at the Harvard School of Dental Medicine. So shout out to anyone from Montreal, Rochester, McGill, or Minnesota who are currently watching. There's 12 of you, so maybe, I don't know. So before we start talking about the socket shield technique, we should start with the basic, which is immediate implant placement. When I first started my first few cases around 5 years ago, there wasn't much literature available on this technique, and it was actually the work of Herzeller that inspired me to look further into this new treatment modality. So adapting this socket shield concept as a subset of the immediate implant procedure, which was more well-researched and better understood, seems to be the natural thing to do. So I will start my presentation reviewing a predictable protocol for immediate implant in the aesthetic zone with rationale derived from current understanding of tissue behavior, biomaterials, and clinical procedures. I will apply this treatment model to the socket shield to propose a socket shield procedure protocol. And finally, I will show some cases that I did applying this new treatment concept. So if you search the literature on PubMed, you can see that immediate implant has shown a huge surge in studies over the last 15 years. There were around 100 articles back in 2000, and now, or the last time that I looked was in 2016, where there were around 500 articles. And more are coming out. So this is definitely a growing interest in this subject. Sorry. So recent systematic reviews have confirmed that immediate implant could be a predictable option in implant therapy. The advantages of immediate implant include faster treatment time, less extensive surgical procedures, lower cost, and less painful for the patient. When properly done, you can also preserve the natural hard and soft tissue around the implant. So let's start with the extraction socket. Needless to say, we need to do an atraumatic extraction to minimize the damage to the hard and soft tissue. It also helps wound healing and visibility of the surgical field. You can divide the socket into 4 different zones, each with its own characteristics. So you have the buccal zone, the proximal or interproximal zone, the palatal zone, and the apical zone. So the buccal zone is the most important zone in dental implant. A very high number of periimplantitis incidents appear to have the implant violating the biological tolerance of this zone. So what we know is there's a pronounced reduction of the buccal bone dimension after extraction, about 40% after the first 6 months, and 50% the first year, up to 5 to 7 millimeters. You also have a vertical height reduction of 1.12 millimeters. So you can see there's an important percentage of bone shrinkage after the tooth is removed. In an animal study in 2005, they have also demonstrated that trauma and loss of periodontal ligament triggers osteoclastic activity, causing bone remodeling. So there's a significant loss in both horizontal and vertical bone when grafting material used versus natural healing. So as you can see, I don't know if I can point on this. Oh yeah, I guess you can see my mouse. So when you do socket preservation, you can see that there's a huge difference between horizontal bone loss in natural teeth compared to socket preservation, and also vertical bone loss compared to socket preserved sites. And thick peri-implant tissue helps maintain crestal bone level. So back in the days, there was this interesting concept where they think that an implant should be placed 1.5 millimeters lingual to the tangent line connecting the root surfaces of adjacent teeth. This so-called safe zone is no longer safe since the buccal bone remodeling will end up just palatal to the safe zone, as you can see in previous studies. So placing an implant here will have a very high possibility of implant losing the buccal support and thus creating recession and not being aesthetic for the patient. So this used to be the ideal implant position. But nowadays we're more looking into a more palatal position of the implant with also a smaller diameter implant. This palatal position facilitates the fabrication of screw retained crowns. Now the smaller diameter of the implant and being placed more palatally and deeper into the bone will help build a better emergence profile. This means subcrestal placement about 1 to 1.5 millimeters apical to the crestal bone to compensate for the bone resorption. Ideally, the vertical soft tissue should be around 3 and 4 millimeters according to Tomasi, allowing around 2 millimeters of barrier periodontium and 1.5 millimeters of connective tissue attachment. So this is how the implant was placed, and grafting the buccal plate or buccal gap and immediate temporation have the most positive impact on crystal bone and maintaining of the soft tissue profile. So usually if the gap is bigger than 2 millimeters, it is recommended to graft bone between the implant and the buccal bone. But as you can see, even with being the most careful, placing a smaller diameter implant, placing it more palatally, there's always a bone resorption. So as you can see, for implant number 8, 9, 10. Sorry, since I'm in Canada, I use the international system. So that would be 2.2, 22. So that implant was restored, and this was around 2 years after the restoration of the implant. And you can see this grayish area around the implant, and also the bone profile not being that thick anymore compared to the other side. So of course you can do soft tissue augmentation with a connective tissue graft, either during or before, during, or after the implant is placed, and it shows very good results. Sorry. So the next zone is the palatal zone. So you know that on the palate there's thicker bone, and soft tissue in this zone may account for less tissue loss than compared to the buccal after socket preservation. An immediate implant placed against the palatal bone also helps the implant stability. The next zone is the interproximal zone or papillary zone. Tissue loss in this area compromise the shape of the papilla, thus affecting the aesthetic outcome. In a natural dentition, the shape of the papilla is decided by the height of the proximal bone and of course the distance between the roots. So distance from the crest of the proximal bone to the contact point, we know that if it's less than 5 millimeters, 100% of the time the papilla will be present. But if it's more than 60 millimeters, the papilla is only present 50% or less of the time. So like in this case, the papilla managed to fill the interdental space because the distance between the bone and the contact point was around 5 millimeters. Okay. Because the distance from the crest of the natural proximal bone to the proximal contact is within 5 millimeters, as you can see on the x-ray, notice, however, that the proximal crestal bone of the implant shoulder is a lot more apical, which bring us to an observation by Joseph Kahn. The height of the papilla is dependent on the level of the proximal bone of the natural teeth, not that adjacent to the implant. So an implant can be placed deep, and you will not lose the papilla if the proximal bone of the natural tooth or teeth is within 5 millimeters of the contact point. And finally, the last zone is the apical zone. There's a high percentage of hopeless teeth that need to be removed that involve periapical access and granulomas, which is apical, which is in the apical zone. So evidence suggests that implant can be placed into an infected site following thorough debridement of the socket. And as you can see here, in the case that we did, there was a granuloma at the apex of the tooth. What we did, we extracted the tooth. We also did an apical surgery together with the implant surgery and proper debridement of the socket. So sufficient bone height and thickness beyond the apex of the root, the root apex, is necessary for primary stability. And another important consideration when placing an immediate implant is the direction of the axis of the implant, which indicate the position of the screw hole. We know that now there are more angulated options available with Astra, Straumann, and other implant companies. But since the shape of the alveolar process vary greatly, preparation needs to be considered on a case-by-case basis. Like you see in this different example, depending on the angulation of the tooth, you should plan your implant accordingly, more palatal to preserve the bone. So this is an example that illustrates the principle and technique. Root fracture with lateral periodontal abscess was there. This is the CBCT, where we can see a thin buccal bone plate right here. The implant was placed more palatally, and this is 4 months post-op with immediate temporization. The treatment was done according to the immediate implant protocol, with atraumatic extraction, small implant diameters placed toward the palatal, placed subcrestal, allowing thick vertical soft tissue, and proper emergence profile. We placed xenograph at the buccal space, and a soft tissue augmentation was also done to compensate for the shrinkage of bone. And finally, immediate temporization. So this is the post-op at 3 years. It shows that there's a stable tissue contour. However, if you look at from an occlusal view, you can see that even if you do everything by the book perfectly, all the different augmentation, there's still an amount of shrinkage and bone remodeling that there's no absolute way of preserving the bone around the implant. So this is why we started to look into the socket shield technique. So if you have any questions during the webinar, I think there's a website where you can post them, and I'll answer them at the end. Webinar is starting. I can hear you, Dr. Nguyen. Have you tried this technique with ceramic implants? So I'm just gonna answer this question from Susan DDS. No, I have not tried it with ceramic implant yet. I don't see why it wouldn't work, because as you can see in this technique, and I'll get back to it, the implant doesn't really touch the socket shield. So either it's a titanium implant or a ceramic implant, it should have the same result. So in both animal and human histological studies, we've looked at submerged vital or non-vital roots, and they've shown that bone formation in new periodontal apparatus coronal to the section tooth was formed. Preservation of roots help maintaining existing bone volume and enable vertical bone growth of the alveolar process. And you can also see the formation of new cementum around the shield and the implant. So in a retrospective study of 46 patients that demonstrated 100% success survival rate and very good crestal bone stability after 5 years post-op. There's also another clinical study on 25 patients comparing the conventional immediate implant to the socket shield procedure, showed that the latter was superior regarding to aesthetic outcome and tissue changes. And another recent human pilot study on the socket shield using digital volumetric analysis showed stable hard and soft tissue after 5 years. So as you can see, more and more longer term papers are coming out on the subject. For the indication and contraindications, you can see that for indication, we can use it at adjunction to immediate implant placement in the aesthetic zone. Situation where minimal alteration of soft tissue contour is necessary, so in very high aesthetic demands. When additional hard or soft tissue augmentation is contraindicated, and when we need to be more minimally invasive in the implant treatments, such as the older population. And for contraindications, periodontal disease involving the tooth mobility of the shield, root resorption involving the buccal fragment, vertical fracture involving the buccal fragment. So if a tooth has a vertical fracture but it's either palatal or away from the buccal shield, it's still a possible option. It's just it can't touch the buccal fragment that we're using. Deep buccal periodontal pocket associated with bone loss, active spreading periapical or periodontal infection, lack of primary stability for implant placement, and buccal bone alteration is necessary at the implant site. Okay, I'm going to try to ask you a question and we'll see if it works. But where would you place the shield in this case? There's 3 positions available. You can see at A, B, or C. So A, you can say it's a bit supracrestal, B is at the level of the crest, and C is below the bone at the crest level. Anyone want to try to give an answer? Okay, I guess it doesn't work. But yeah, there are 3 positions available for the socket shield. So by leaving the socket shield 1 millimeters above the crestal bone, you can see that connective tissue attachment is left undisturbed, and this position is basically apical to the epithelial attachment at the base of the pocket depth. By placing it lower at the crest level, it will defeat the purpose, because this will go into the biological width. So it will sever all the connective tissue attachment and create a recession. And if you cut down the shield below the crest level, this will further compromise the biological width of the tooth and create more gingival inflammation and further recession and bone loss. So basically, position A is what we want to achieve. Slightly 1 millimeters above the crestal bone, so then the epithelium can migrate over, but still maintain the connective tissue attachment. So if you look on this drawing, the shield should be 1 millimeter above the buccal bone crest. It should be 1 to 1.5 millimeter thick. And it doesn't go all the way to the base of the socket. It should be between 5 to 6 millimeters in height, more coronally possible. The width should be between the buccal proximal line angles of the tooth. When we look at it from a lateral view, the shield should be bevel at the internal coronal aspect to avoid direct contact with the abutment and the implant. You should avoid any sharp edges, which can cause shield exposure, and a thorough debridement of the socket of pathologies and dental debris should be done. When placing the implant, it should be a small diameter implant. Implant placed in the palatal position, like previously mentioned. It should not touch the shield. An implant should be placed at least 1 millimeter subcrestal and 4 millimeters away from the gingival margin. Primary stability should be, just for any immediate implant, minimum 35 Newton centimeter for immediate temporization, and bone augmentation is not necessary within the socket gap. So now I'm going to present a clinical case that I did. So the lower image that you can see showed the original situation of this 72 years old patient seeking treatment to replace missing upper posterior teeth. Shortly after the treatment was completed, 2 of her crown fractured at the gum line, and the situation required removal of the roots and immediate implant treatment using the socket shield procedure. So the shield presentation just before the implant were placed. This is a post-op photo right after the implant insertion and immediate temporization. This is a photo of a 5-year post-op. The gingival tissue appeared to be in perfect condition. And you can look from the occlusal view as well. And what we did was we used a geomagic engineering software to superimpose the scan of pre-op and 5-year post-op of the model. And the color mapping shows less than 0.3 millimeters of discrepancy at the soft tissue region around the implant. So just to conclude, the socket shield technique has huge potential, as you can see, and you can see in many other studies. It's currently not evidence-based because there's not enough evidence and research done on the topic, but this is only a question of time. Of course, you can't just go around leaving tooth fragments here and there, and this is why we wanted to have a proper protocol on how the fragment should be left and how you can shape and arrange the fragment. And yeah, this is very well perceived by the patient. A lot of people ask what happened to the fragment. What if we have gingival recession? What if the fragment is exposed? From the cases that I've done, there's after the implant is placed and immediate temporization, or even without immediate temporization, the epithelium will migrate on top of the shield, so it's not present when you will restore the implant. Of course, you need to be careful not to have sharp edges and make sure that your crown doesn't sit right on top of the shield. But if there's any exposition you just need to anesthetize the patient, grind down the tooth fragment a bit more, let it heal, and come back and put the crown on. There wasn't any case so far that needed to remove completely the fragment, and this could be a problem. But just like any soft tissue around an implant, if you don't brush like crazy, I don't think there's any recession that will be naturally occur just like this. So thank you for your attention. If you have any question, I've left my Instagram account and email, so you can just email me. And I will be open for questions if you have any. So a lot of you answered B to my question. I think there's a lag in the with the software, but no, the right answer was A. But thank you for answering, Jen, Susan, and Mac. Crystal, I think that was the implant placement, not the shield. You're right, Mac. All right, thank you, Mac. Do you guys have any other questions? Yes, so I use, there's no specific burrs that I use. I use whatever is available. And I have to say that it takes a lot of time, and it is very technique sensitive to prepare the shield. It's not just taking your surgical burr and cutting the tooth in half and go down and then placing the implant. Like I said, you need to follow a certain shape. The most difficult part is to keep only 5 to 6 millimeters in height and remove the rest. And also during the extraction, you have to be very careful not to push the fragment to buckle and then break the buccal plate. But I just use any long burr that I have. For the bevel, I use a long diamond burr that we use for crown prep. And I just do the about 30-degree bevel on the tooth fragment. To cut the tooth, I do use a surgical burr at the beginning, being very careful and seeing away from the buccal plate. But yeah, it takes me a lot of time until the fragment is perfect. And this is something that I've learned through different cases. Sometimes you rush a bit more and you don't round all the edges, and for sure there's gonna be perforation and exposure of the shield. So this is the most crucial part, and you should really take your time to prepare the shield. So Susie is asking, what technique do you use, piezo or burr? You can use a piezo, but I usually use a burr just to cut the shield and prepare it. Do you typically section the shield before elevation of the part of the root that needs to be extracted? Yes, I try to never elevate the shield, because you don't want to compromise the periodontal attachment of the buccal shield. So I cut all my pieces first into half, try to elevate the palatal portion, take it out, and then I try to shape the thickness of the shield. After that, I would remove the apical part and try to take it out with apexos or any type of instrument that you use to remove root fragments. And then finally, I would finalize the shape, the shield's contour, putting the bevel, making sure everything is rounded. So Crystal is asking, how do you determine 5 millimeters of the shield? My favorite instrument is the UNC probe. which is 15 millimeter long. So usually I just put it into the socket and eyeball something bigger than 5 millimeters. So usually it's between 5 and 6. And I think you can easily see it with your probe, since it's at the coronal portion. Thanks, Matt. How do you do if primary stability is less than 35 Newton centimeter? What do you do? This is a very good question. So do you really need to temporize every cases? The answer is no. So if you place the implant and the stability is less than 35 Newton centimeters, what would I do is I will stage the implant. So I will put a cover screw. Sometime I would graft in between the buccal space, and then you can put anything on top of the socket. It could be collagen membrane. It could be a punch from the palate, or it could be just a color plug, and then you just let everything heal and come back after 4 months to do second stage. So at second stage, I would either do a custom temporization, custom healing abutment, or a temporization before taking the final impression, because you need to work the emergence profile and contour before taking the final impression. Ooh. So why did I say it's not necessary to graft the gap? Is because other studies have done it without grafting the gap. So evidence so far showed that you don't really need to graft the gap. It will be filled with your blood clot, and natural healing will occur. And since the buccal plate is still maintained, there's vascularization coming from the periodontal ligament around the fragment, and this will maintain the space, and anything in between will turn into bone. So this is why technically you don't need to do it, especially when you do temporization. I feel that the hole is covered and everything is well maintained. But if I have to stage it, usually I would just graft into it to be sure. But you really don't need to. Sarah Rossi, why did you say? Oh, I answered that. Not how do you measure. Why do you choose this length? So the reason is more of a practical thing, because if you leave it for too long, or the more roots that you leave, the more difficulty you will have. It will be difficult to keep it thin enough. It can touch the implant, and also you have to remember that sometimes there are periapical abscess and granulomas, so it will impede your cleaning and debridement of the socket. And basically what you want to do is to keep the coronal portion. If I say 2 millimeters, 3 millimeters is too short, but I find that 5 to 6 millimeters is an appropriate length. Of course, you can go 7, 8, 9, 10 if you want. But, the longer you leave it, the more, like I said, it can touch your implant, and it can give you some more troubles and headaches. So that's why I try to keep it as minimal as possible. But it's a very good question. Thank you, Michael. Thank you, Jen. Thank you, everyone. Is there any more questions? All right, I think we're good. So once again, thank you, everyone. And if you have any questions, you can just send me a message on Instagram or by email. And if you want any more topic or any webinar, just let me know and I'll work something out with Blake. Thank you.